Respected Chairperson, Panelist, and my dear colleagues, after such a beautiful presentations by the legends, I am little bit nervous to present my case here. So my topic is a journey through a reverse route. This is a 60 years male hailing from Chatpur with ongoing chest pain for 4 days, and he was admitted in a private hospital where I routinely practiced, and on admission, his pulse was 124 beats per minute and blood pressure was 110/70. He had a history of COVID 3 months back, and he had the same type of chest pain 1 year back. And for the last 1 year, patient complains of ongoing chest pain, that is CCS class 3. And his ECG shows that is old MI inferior with features of dextrocardia, and the X-ray shows this dextrocardia, right-sided aortic arch with fundic gap shadow in the right side. So most probably this is a case of, and his echocardiography of a few months back shows the dextrocardia inferior hypocondition is good, and is a mild LV systolic dysfunction that is 46%. So troponin was raised, and he has already a previous ultrasound which shows the situs inversus, that is everything is in the reverse side. So my diagnosis was non-ischemic with refractory angina. That patient was ongoing chest pain with maximum medication, and old MI inferior, and mirror image dextrocardia with situs inversus. So ACC AHA guideline 2021, according to the guidelines of non-ischemic, it shows that if the patient is cardiogenic shock or refractory angina or hemodynamic instability or electrical instability, we must have to do the invasive strategy within 2 hours or as soon as possible. So but the problem is, we are doing, I doing my evening practice or in a center that where this is the angiogram machine is in the older version. There is no IVAS, FFR or guide catheter, route is unknown, there is ongoing chest pain, but we cannot wait. Look, the entry of the catheter, coronary catheter over the guide wire, that is from the right side, sorry. In the left panel, in the right panel, look, this is RCA or left system. This epicranial view shows the LED is 90% occluded in the stenosis in the proximal part. This is spider view, epicaudal view showing the same. And LEO view for the RCA shows that there is complete occlusion of the distal part of the RCA. So it is a case of mirror image dextrocardia, right-sided aortic arch, RCA CTO with multivessel disease. I have experienced only 4 cases of dextrocardia in my 12 years of interventional cardiology career, but I have no experience on dextrocardia PCI previously. And my cath labs team have no experience of handling such cases of dextrocardia PCI. So this is the great problem for me. And for this, I am little bit nervous for that, but I cannot avoid saving a life. So for this issue, I discussed with their relatives, because this is a patient of non-STMI with LED 90% and RCA CTO. According to the guideline, I want to fix the LED first. Pre-dilated stent was positioned. Stent deployed. And after that, 3 into 12 NC balloon was dilated. And this is the final view of this. You can appreciate the result. But after that, when I tried to complete my procedure, the party came to me that, sir, please complete the RCA also. I repeatedly denied to do that because this is a CTO, I think this is a CTO. But they are thinking that as most of our patients, they have a low budget, and they are trying to, they are finishing this second work within this budget. So again, I tried to negotiate the wire. My workhorse wire would run through floppy wire with the balloon support, but failed. Then I changed to pilot 150, and again tried many times, failed. Then tried with pilot 250, tried for another 30 minutes. 2 hours already passed. We failed to ensure the integrate flow in the RCA. Finally, wire exchange with Fielder XT with balloon support, and he still could not find the integrate flow. In this time, patient complaining of chest pain, pulse, rapid three-dip, and BP, his vitals are going down, there is crepes, high flow oxygen injection, furosemide, and injection already started. I again checked for any dissection or perforation or any thrombus, and look, there is a white shadow in the proximal part of the RCA, and ACT checked, and it was less than 180 seconds, and IV heparin and intercoronary bolus in FT fever was given, and we are waiting for stabilizing the patient. Sometimes we may or may not reach our target with maximum efforts. And after waiting for the procedure, finally, after stabilizing of the patient, I crossed the lesion finally, and tried another 1 hour and finally crossed with Fielder XT. And serial ballooning with 1.5 into 12 and then 2 into 15 millimeter uncompliant balloon. Drug leaking stent was implanted, and this is the final view. Finally, I took breath. Now, tips and tricks of the mirror image dextrocardia offers a technical challenge to the intervention cardiologist due to its abnormal anatomical position of the heart. Sometimes right position of the right, that is right sided aortic arch, unfamiliar coronary anatomy, especially at their origin. Horizontal axis double inversion technique was developed for image acquisition. A mirror image between LAO and RAO using an image reversal technology will give an advantage to the operator for the intervention. RCO was engaged using an opposite maneuver. The important tricks is that we have to torque the RCA with the opposite technique, that's in the anti-clockwise, with the tip of the catheter pointing leftwards and rotated counterclockwise instead of rotating clockwise. This is the main tricks. Transfemoral access gives a better access, even though some reports of transradial approach are also good for dextrocardia cases. In cases with an isolated right aortic arch, a left Judkins catheter can be used for selectively cannulate the left coronary artery and is also able to cannulate a right-sided coronary artery. But in this case, I am fortunate enough to cannulate the RCA with the right Judkins in this case. The take-home message is the incidence rate of mirror image dextrocardia in the general population is estimated at 1 per 8,000 to 1 per 25,000 of population. Interventional cardiologists may have to handle such type of cases, as this is not so rare. Knowledge regarding anatomical orientation, image acquisition, torquing direction, guide catheter selection and direction, wire escalation can help to overcome the challenges. Thank you for patient hearing.